collaborating to meet challenges and opportunities, the state of Maryland's health. In today's summit, you will gain insight to new and innovative collaborations and partnerships to help meet the nursing's future healthcare challenges and recognize opportunities in how we can all improve our workplaces in Maryland. Before we begin our formal program, I would like to cover a few reminders. Participants will be muted upon entrance to the virtual session, so please type in the chat any comments, concerns, and any questions. Please note to put them in the Q&A section. Please use our platform networking tab to communicate with other attendees. This is located in the virtual lobby. Also, if you are in need of technical support, out in the lobby, you will see an info desk, and they'll be more than happy to help you with any technical issues. Please refer to the MDAC Summit Guide for additional information. You should have received this guide in your email when you received the link to the summit. The guide helps provide the agenda for today, the presenter's full bio, and a list of the posters and roundtable discussions that will occur later today. You will also find information on how to join the Maryland Action Coalition. Just a reminder, our poster hall will be open all day for you to visit and read all the innovative work that's being done. You will see an electronic evaluation after today's events. So please, once you complete the evaluation, you'll be able to print off the certificate of attendance or your CE certificate if you chose the CE option. Please share your experience on social, hashtag MDAC 2023. You will note that the presenters and planning committee have no relevant financial relationships with ineligible companies to disclose. The University of Maryland School of Nursing is an accredited with distinction as a provider of nursing continuing professional development by the American Nurses Credentialing Center Commission on Accreditation. Nurses may receive 6.25 contact hours of nursing professional continuing development. In order to receive this credit, you will need to complete the evaluation. Certificates of credit can be downloaded once you complete the evaluation through the electronic system. If you have any questions, please email the Office of Professional Education at the School of Nursing, and we'll be more than happy to help you out. Again, thank you for being here this morning. It is my great pleasure to introduce the Bill and Joanne Conway Dean of the University of Maryland School of Nursing and co-chair of the Maryland Action Coalition, Dr. Jane Kirschling. Dr. Jane Kirschling was appointed Dean and Professor of the University of Maryland School of Nursing and Director of Interprofessional Education at the University of Maryland, Baltimore in January 2023. She is nationally recognized as a leader in nursing, having served over decades on the board of directors of the American Association of Colleges of Nursing, including 2 years as its president, and she continues to be active at the national and local level within Maryland. With Dr. Pat Travis, she co-leads the Maryland Action Coalition, which has implemented the 2020 recommendations of the Institute of Medicine report and the future of nursing in Maryland, and is presently addressing the most recent report that was released to raise really important issues within Maryland. Before we welcome the Dean, I would like to introduce Dr. Mary Etta Mills, who has a special presentation to the Dean that she would like to share.
Thanks so much, Dr. Bullock. Dr. Kirschling, the leadership you've provided for the Maryland Action Coalition is immeasurable, and it deserves to be recognized and celebrated. The Maryland Action Coalition is proud to present a special award to you. You will receive or have received a vase, which is inscribed with the following: in gratitude for a decade of Maryland Action Coalition leadership and your commitment to transforming healthcare in Maryland, 2013 to 2023, Jane M. Kirschling, PhD, RN, FAAN, May 22nd, 2023. Thank you for all of us.
So thank you, Dr. Bullock, for the introduction and for the logistics. And thank you, Dr. Mills, for that very kind gesture. You know, the thing about leadership is that it takes a village to do it. And I have been so fortunate to work with all of you here in Maryland as I wrap up my career and my work both with the Maryland Action Coalition. So the vase will be proudly displayed in my new home in Silverthorne, Colorado. And I promise that if you come to visit, I will make sure that there's fresh flowers for us to enjoy. So on behalf of Dr. Pat Travis and myself, we welcome you to today's program. Before we get going, I want to thank the members of the Planning Committee who are indicated here. In addition to Dr. Travis and myself, the committee includes Dr. Lynn Marie Bullock, Dr. Marietta Mills, Dr. Rebecca Wiseman, Jordana Signeri, Anjali Sonier, Sonia Smith, and Stephanie White. Thank you to each of you for your efforts in making today's summit possible, and especially to the staff. You are the glue that holds us together, and we are forever grateful for your support. I want to particularly acknowledge several individuals affiliated with the Maryland Higher Education Commission who have been critically important in terms of our ongoing work in today's program. First, of course, the late Dr. Peggy Daw, who until her very untimely passing in December 22, served as the program administrator for the Nurse Support Program 2. I'll say a little more about Dr. Daw's contributions in just a few minutes, but as you all know, she was the driving force behind much of what we've been able to accomplish here in Maryland. I want to also acknowledge and thank her dedicated colleagues who are continuing her work. Dr. Laura Shank, Grant Administrator for the Nurse Support 2 program, and Ms. Kimberly Ford, the Assistant Grant Administrator for the NSP2 program. As you know, the NSP2 program is funded by the Maryland Health Services Cost Review Commission and administered by the Maryland Higher Education Commission. This unique program has been critical to our ability to increase the number of nurses in Maryland, support nurse faculty, support collaboration between academic and clinical practice nurses, and through the institutional grants program, launch innovative projects around the state. We will have an opportunity to hear from Dr. Shank and Ms. Ford later this morning, and we'll also hear more about some of the projects funded under the NSP2 program during the day. But I want to take this moment to let you know that we are indeed grateful for their efforts in carrying on this important work. So thank you, Dr. Shank and Ms. Ford, for your support of nursing in Maryland. I also want to acknowledge the support of the Maryland Nursing Workforce Center, directed by Dr. Rebecca Wiseman, who also serves as the director, who also has been serving as the chair of the University of Maryland School of Nursing at the universities at Shady Grove until a year ago. And we are very grateful. The Workforce Center has generously helped to defray expenses for this meeting, making it possible for us to offer this program without a registration fee. The center exemplifies the type of initiative launched through funding from the NSP2 grant program. Established in 2018, the center collects, analyzes, and reports on the state's nursing workforce, helping us better understand the current and future demand for nursing personnel and the resources needed to meet these needs. The center is one of 36 statewide organizations that are members of the National Forum of State Nursing Workforce Centers and provides an important locus for nursing workforce data and related issues. So thank you, Dr. Wiseman, for your leadership of the center and the center's support for today's program. I want to provide a bit of context for today's summit by reminding us of our history. The Maryland Action Coalition was formed in 2010 following the release of the Institute of Medicine's report on the future of nursing, leading change, advancing health. That report outlined a series of challenges for the nursing profession, with a particular focus on preparing the nursing workforce to meet the demands of providing care to an increasingly diverse and aging population, and doing so in the context of an increasingly complex healthcare system. From the very beginning, our Maryland Action Coalition has been part of the Future of Nursing Campaign for Action, an initiative of the Robert Wood Johnson Foundation and AARP, established to implement the recommendations of the report through coalitions in each of the 50 states and District of Columbia. Here in Maryland, our efforts have been enormously successful. We've expanded the number and percent of baccalaureate educated nurses in our state and significantly increased the number of doctorally prepared nurses, two key components of the 2010 recommendations. In addition, with the establishment of the Maryland Nursing Workforce Center, we are addressing the need for better workforce data another key recommendation. And Maryland has been successful in reducing the barriers to practice for advanced practice nurses. We've also made important progress on addressing the diversity of nursing with an increasingly diverse cohort of nursing students and greater diversity among nursing faculty. More recently, the National Academy of Medicine issued a subsequent report, The Future of Nursing 2020 to 2030, Charting a Path to Achieve Health Equity. During recent MDAC meetings, we've discussed our individual and collective responses to these further recommendations. As you may recall, a key theme of that report is the need to address the social determinants of health, reduce health disparities, and address inequities in our health system. These were not new and novel challenges, but they are certainly brought into sharper focus given the disparate impact of the COVID-19 pandemic on selected populations. Another outcome of the COVID-19 pandemic has been the significant toll that it has taken on nurses throughout the country, particularly the level of moral distress and burnout experienced by nurses on the front lines of care delivery. How to best address this is the theme of several of today's presentations. Our agenda for today includes discussing some of the important initiatives underway to deal with the challenges of a post-COVID world and to continuing to address the core challenges laid out in the recent report. This year's summit theme, which is collaborating to meet challenges and opportunities, the state of Maryland's health looks to our future. We will spend today exploring some of the new collaborations and partnerships that are helping us address the current challenges, including developing new models of care, staffing to better support nursing retention, partnerships for preparing students for future healthcare needs, and exploring implementation of long-term sustainability change within Maryland's health system. Threaded throughout all of these is the need to recognize and support the vital role of nurses in implementing strategies for academic and practice-based responses to the needs of our healthcare system and those patients, families, and communities that we serve. So we've come a long way since the beginning of the Maryland Action Coalition in 2010, and it's not surprising that new and complex challenges continually emerge and require innovative approaches and strategies in response. Given the exceptionally collaborative and collegial relationships that we are so fortunate to have here in Maryland, I'm confident that by working together, we can successfully respond to these challenges and leverage the opportunities before us. So thank you for being here today and for being a part of this important work. At this time, I want to present the Maryland Action Coalition Exemplary Leadership Award. This award was created in 2022 to recognize and celebrate the leadership and accomplishments of an individual that go beyond their day-to-day responsibilities. The award also serves to recognize an individual who honors diverse perspectives and includes others while exploring new ideas and partnerships to achieve large-scale goals. This year, I'm pleased to announce that we have renamed this award in honor of the incredible legacy and many contributions of Dr. Peggy Daw. Going forward, this Maryland Action Coalition Award will be known as the Dr. Peggy Daw Exemplary Leadership Award. As many of you know, on May 9th, representatives from the nursing community from throughout Maryland gathered in person and virtually to celebrate Dr. Daw's legacy. At that time, we were able to present the inaugural Dr. Peggy Daw Exemplary Leadership Award to Dr. Daw's family, as represented by her mother, Mrs. Ruby Daw, and her daughter, Miss Lindsay Ivy. They traveled from North Carolina to be with us. They had the opportunity to hear firsthand the many beautiful tributes honoring and celebrating Dr. Daw for her many contributions to education, research, practice, and policy. At the time of sharing the award with her family, I commented on Dr. Daw's many contributions, including her support of the Maryland Action Coalition since its launch in 2010, as follows. Over the intervening 13 years, our efforts here in Maryland have been enormously successful, in no small measure because of Peg's deep commitment and her involvement in helping to make available the resources and support that could move a national agenda forward here in the state of Maryland. Whether that agenda was to expand the number and percentage of baccalaureate-educated nurses, to increasing the number of doctorally prepared nurses, to establish a Maryland Nursing Workforce Center, to address the need for better workforce data, or one of the countless projects to foster improvements in how we teach and practice, Peg was there every step of the way, helping to make the daunting not only possible, but a reality. So please join me in a virtual applause as we honor Dr. Dawes' memory and her many accomplishments with this award, now renamed in her honor. Thank you so much. We will now move into our fireside chat. As you know, it is my pleasure to introduce and moderate our first session of the day. We are fortunate to have with us the presidents of 3 of Maryland's most significant healthcare systems. I'll introduce each of them in just a moment, but in framing this conversation, I suggest to them that we focus on the following items: leadership lessons learned from the challenges faced during the COVID-19 pandemic, critical issues facing us as healthcare professionals, both immediately and 5 years from now, the work that our systems are undertaking to address health inequities, and the directions that systems might take to increase interest in nursing and grow and retain the nursing workforce. So given all that we have to talk about, I'll introduce each of them very briefly, but would encourage you to read the longer bios that we've included on the website for this summit, as I cannot do justice to their many accomplishments in the time available. With that, I'll introduce them in alphabetical order, beginning with Dr. M. Joy Drass, who is the Executive Vice President and Chief Operating Officer for Medstar Health, with executive oversight of 10 hospitals, as well as integrated operations, nursing, and operational support. She also has executive responsibility for Medstar's entities related to ambulatory services, health home care, National Rehabilitation Network, and the medical group. She previously served as Executive Vice President of Operations for the Washington region, with responsibility for system-wide human resources and nursing functions, as well as regional program development and operational synergy among the DC entities for Medstar Health. Prior to her system-wide responsibility, she was the president of Medstar Georgetown University Hospital for 9 years, including overseeing its clinical enterprise and faculty practice. Dr. Drass is an alumna of the Georgetown University Medical School and completed her residency and clinical care fellowship in the Washington, D.C. area. She also holds a master's in business administration from the University of Pennsylvania Wharton School of Business. Prior to assuming executive leadership roles, she was an interventionist for more than a decade in the surgical intensive care unit and the trauma unit at Medstar Washington Hospital Center. She currently serves as the chair of the District of Columbia Hospital Association Board of Directors, as well as on numerous other boards and committees. Mr. Kevin Sowers is the president of the Johns Hopkins Health System and executive vice president of Johns Hopkins Medicine. He is the second person in Johns Hopkins history to hold these dual roles. He oversees the system's 6 hospitals, which are located in Maryland, Washington, D.C., and Florida. He also serves as chair of Johns Hopkins Community Physicians, with more than 40 primary and specialty care outpatient sites throughout Maryland and the District of Columbia. Mr. Sowers joined Johns Hopkins Medicine after 32 years with the Duke University Health System, where he served during his last 8 years as president and CEO of Duke University Hospital. He originally joined Duke Hospital as a staff nurse in oncology and then held several faculty and nursing leadership positions. He holds a Bachelor's of Science in Nursing from Capital University School of Nursing and a Master's of Science in Nursing from the Duke University School of Nursing. In 2020, he was recognized by the Columbia School of Business with its Deming Cup Award, honoring business leaders for merit in operations and for fostering a culture of improvement within their organization. And Dr. Mohan Suntha was named President and Chief Executive Officer of the University of Maryland Medical System in November 2019. UMMS is a nationally recognized academic health system, employing over 28,000 individuals across Maryland at more than 150 locations, including a network of academic, community, and specialty hospitals. Prior to his current position, Dr. Suntha served as the President and Chief Executive Officer of the University of Maryland Medical Center, and prior to that, he served as President and CEO of the University of Maryland St. Joseph's Medical Center. Dr. Suntha received his MD degree from Jefferson Medical College and his MBA from the Wharton School of Business at the University of Pennsylvania. Dr. Suntha came to the University of Maryland Medical System and the University of Maryland School of Medicine as a resident in the Department of Radiation Oncology. He joined the faculty in 1991 and developed a national reputation for the management of head and neck and thoracic malignancies. He was named Chief Vice Chair of the Department of Radiation Oncology in 1997, and subsequently in 2008 became a tenured professor and the inaugural Maryland and Stuart Greenebaum Endowed Professor of Radiation Oncology. He continues to maintain his faculty and clinical appointments. So please join me in warmly welcoming our participants to the Fireside Chat. And we will begin then with the talking points that we asked each to address. So starting with the leadership lessons learned from the challenges faced during the COVID-19 pandemic. And actually, we're going to start with a different one. So as you think about the next 3 to 5 years, what are 2 to 3 major challenges that Maryland's healthcare systems will need to navigate? And how about Dr. Suntha, I start with you.
Sure. Thank you, Dean Kirschling. And as I begin, let me just express my profound gratitude to you for the years of partnership, both in my role at the medical center and now at the system. I think you've distinguished yourself as a phenomenal leader who's understood the value of critical partnerships. And we'll get to that conversation about lessons learned and the importance of partnerships later on. But when we think about our view of the challenges that Maryland's healthcare systems are going to be facing over the next few years, undoubtedly, as this Fireside Chat highlights, the conversation about labor and the need to evolve how we think about first retention of talent and then recruitment of talent is foremost in our minds. There is no question that the last few years have uncovered the need to reimagine how we think about engaging a workforce and ensuring that we're able to deliver on our mission. So labor would be number one. Then the next few, I would say, for the uniqueness of the Maryland model, what we like to call the incubator for the nation, the reimbursement model in the state of Maryland certainly is going through an evolution and partnering with our state colleagues and our federal colleagues to ensure that Maryland as a state can help the nation understand and drive to a value-based reimbursement system that allows us to still accommodate and deliver on the commitments of academic medicine, to understand and take on the challenges of urban-based safety net healthcare access points, and to deliver on rural healthcare. These are the types of challenges that the evolution of the model needs to consider as we move forward. And then the last thing I'd say is we have seen undoubtedly a growing presence of what we in acute healthcare may call external forces or disruptors in the healthcare continuum. But disruption can be a phenomenal force for positive change as well. But I think as we think about healthcare delivery, how we acknowledge the role that these disruptors have in the healthcare continuum, and then how we figure out how to either align and or address the continued gaps in care. Those are probably the 3 major challenges that our health system spends a disproportionate amount of time thinking about.
Thank you. Dr. Drass, would you like to go next?
Yes, thank you. So I would agree, obviously, with everything that my colleague just said. And because I'm from the ops world, maybe I'll take us down a little bit into a little more detail around some of them. So if you said to me, what are the 2 or 3 challenges? My answer would be workforce, because I do believe that is the critical challenge for us as we go forward. And just to make 2 additional points around that, I think the first is that the shortages are not just in nursing. We are seeing significant shortages in all categories of our frontline care providers, whether it's advanced practice nurses, respiratory therapists, pharmacists. I mean, the list goes on. So the strategy and how we close that gap will need to be broader than nursing, although that clearly is our most critical shortage. I think the second point that I would make is that as we think about that shortage of nursing, what's really struck me recently is that this anticipated shortage is really staggering when you look at some of the data that's coming out for the next 5 years. Whether it's the recent survey done by the National Council of State Boards of Nursing and what their prediction is of nurses that are going to retire or leave the profession, or another survey that I saw that was done for hospital employed nurses that basically showed that only 15% of them will continue working as they are today a year from now. So I think we have to confront the challenge that this is really a staggering change. And I think as we stare down that imperative, there are 2 points that I would emphasize. One is that the hospital model of care is going to have to evolve. It's not a choice that we make. It's going to have to evolve when you look at some of the data in terms of the nursing pipeline. And so I think our goal for all of us has to be that nurses work to the top of their license. And I think this new model of care, as we move forward, will have nurses working at the top of their license, but supported by a team in order to continue to deliver high quality care to our patients. That's a major transition as we think about it. And I'm focused right now on some of what I think are the pain points. And the chief one of those that I hear from our nursing group is electronic health records. So our nurses tell us that they spend 30% of their time charting in the EHR. So I think some coordinated effort to relieve that burden, whether that be by added technology or whether we reevaluate what it is that we're asking for in terms of data, I think will be really important. And then my final comment would be that it is very clear to me that the model of care going forward is going to have to change. And that transition will be very disruptive to our nurses, both current and those coming into the profession. And so I think investment in educational resources and wellness resources to help our nurses make that transition is going to be really foundational to our success as we move through the disruption.
Thank you. Mr. Sowers, welcome.
Dean Kirschling, thank you so much for having me today. It's a pleasure to be here with my colleagues. I would agree with everything that has been said, but I would highlight a couple other areas that I would focus on. And number one is workplace safety. I think we've all seen an increase in violence in our workplace, and that's a very varying degrees. And so I know at the federal level, there's a bipartisan bill that's moving forward, much like we saw with the airlines and making it a federal offense to cause harm to a healthcare worker. But I am concerned about that, and not just from a violence perspective, but just coming out of the pandemic and knowing the moral distress that people experienced during that time. Also looking at the impact on, as my colleague spoke about, the wellness piece, not just about the changes we're going through in healthcare, but just coming out of the pandemic and looking at the mental health issues that now exist amongst our providers at a higher level than we've ever seen before. And so the combination of those two in keeping a healthy workforce is critically important as we think of the future. I want to go to care redesign for just a minute, because I do believe there are two things that happened. There's a supply and demand issue, but there is also now an economic issue we have to deal with. And that is the issue of payers have not stepped up and provided us additional resources. So because of the costs that we've had to put into the workforce, we are going to have to rethink our care delivery models. And for me, as I think about that, I do believe, as Dr. Drass had said, They will be team-based. But what does that team look like? Is it a nurse practitioner with newly designed roles that's overseeing a segment of a unit? And the nurse practitioner is able to practice to the full scope of their license using patient care techs. Is it a nurse using telehealth to direct the team as we think about putting cameras in rooms to have a nurse interact with patients and directing team members? Is it EMTs in our emergency rooms having a different scope of practice? And as we think about those changes, we're going to need to partner with schools around what our supply and demand looks like for the future. And we're also going to need to focus on practicing our partnering with our other agencies and regulatory folks around what will have to change in terms of scope of practice guidelines as we move to the future. So I continue to say to my colleagues, this is not something that's going to happen in the next year, because as you look at all the pieces and parts you have to pull together to make this happen, it's a 5 to 10 year journey as you start to think about that. Here, as we started that work, I've also partnered with the School of Nursing, the Hopkins School of Nursing, because it's incredibly important. I think that as we make these changes, we study these models around quality and safety to assure as we make these changes that we're not negatively impacting any of the quality and safety that we've been committed to for so long. And so I see those as additional items that we have to think about in the coming years as we think about the changes that we'll have to put in place for healthcare.
So 2 follow-up questions. One is very pragmatic and the other is probably a tad bit volatile, and that is, do you think wellness is possible within a 12-hour work schedule? When oftentimes my bet is that the nurses aren't just doing 3 12s, but they may be doing 4 or 5 because they're picking up other opportunities.
Is that to me, or is that?
Or anyone, just to anyone, because it's a
So
12-hour
maybe
day. And yeah, go ahead, Mohan.
Yeah, I'll jump in and say, I think you highlight one of the challenges when we think about how we reimagine care delivery. And a piece of that conversation is with wellness at the forefront of conversations. How do we optimize schedules that allow for quality care delivery and also nurturing the wellness of our workforce? And I think this conversation about numbers of hours worked, nursing is not we've seen these conversations in other parts of the healthcare delivery system from years ago. And I think, at least at our institution, being more flexible with the amount of hours in any shift is part of a strategy that addresses both wellness, retention, and recruitment when you think about the workforce desires in terms of flexibility that they are going to demand of us as organizations. And so I think this is a conversation that is in the forefront of our minds and is actually leading to change from the traditions of 3 12-hour shifts. Because to your point, we see plenty of folks in our organization who do far more than that. And then that causes other stresses.
Yeah, I agree with that, and I'm going to be even more provocative. The conversation that we've been having at my system with nursing is that the model of a patient care unit within a hospital having a relatively, my word, permanent staff, i.e. a certain number of nurses that are there and continually work on that unit, and they work 12-hour shifts, 3 or 4 times a week. I think that model is a legacy model. And over some period of time, I believe it will disappear. I think what we need to be ready for is a new model, which speaks to the comments that both of my colleagues made. And I think as we fast forward 5 years, I'm making this up, but if we fast forward 5 years, I think those units are going to be staffed with nurses coming from a number of different perspectives. And again, because that's what they want, the flexibility that they want. So the number of nurses who are permanent in the sense of some continuity on the unit will be very small. And the staffing will be filled in by those nurses who want to work less number of hours per week, those nurses that want to be travel nurses because they want to travel and they want to have different experiences, whatever it happens to be. And I think that the challenge for all of us is to design a system that allows us to orient these additional nurses to the clinical protocols that we have so that we can continue to provide quality care. And so I think that piece is going to have to change. And I do believe I think to some degree we're already seeing it, but not to the extreme. But I do believe that trend will continue because our new to practice nurses coming in through the pipeline really want greater flexibility.
In Kirschling, I will even be a little bit more provocative. And you know, when I became a nurse in 1985, we worked 8-hour shifts. And the only reason I bring that up is this is a generational discussion. This is not just about the difference between 12-hour shifts and well-being. And you know, as I said to some of my colleagues the other day, we were having this discussion. You know, the generation that I grew up in, you work the work, and the most important thing you could do is stay a long time in an organization. That is not how this generation focuses their time. Their focus is more on how much time do I get off versus how much time do I work. And that I said to someone, maybe they have it right, maybe we had it wrong. And so how do you change your frame of thinking as a leader to support generational differences? And I truly believe this is a generational difference in terms of wanting to work the 12-hour shifts, because if you schedule correctly, you can actually get 7 days off without actually taking PTO. And so that is a generational difference that we have to acknowledge. And maybe they did get it right, because in that time they have off, maybe they are able to do things that they're able to do in terms of their own well-being. The second piece I would say, though, that I'm seeing is we have to admit to ourselves as healthcare providers that discussing our mental health issues is okay. We have to create a safe place within our environment where it's okay to acknowledge that people are struggling with depression, anxiety, or maybe other mental health disorders. We have not normalized that, and it's been seen as more disruptive in terms of your workplace if you acknowledge that. We have to create environments where it's okay and provide the resources to support our workforce around that and give them time, as much time as they have at the bedside to equal out the time they have to take care of themselves. And that requires us to be more flexible than we have in the past. And so two things, generational and then normalizing the culture to talk about it and that it's okay to be struggling and needing help.
So thank you. My other just curious question is in Maryland financially in a worse position or about the same as the rest of the nation, given the Medicare waiver? When you think about,
I do believe I'll start that we because of GBR, we were provided somewhat of a cushion that the rest of the nation did not have. Do we still struggle? Absolutely, we do, because the labor costs and the supply costs for us are just the same as the rest of the nation. But with a guaranteed budget, revenue, you do have some cushion that the rest of the country did not experience during that time.
Yeah, so I would say Kevin's absolutely right that during the pandemic, The waiver created stability in the state of Maryland that other states did not enjoy. I think when you look at the broader lens of how health systems of our size and scale, the collective systems that are represented on this call, when you look at their global performance in the nation, there has historically been larger margin creation, painting with a broad brush when I say that, which therefore created more cushion within the resources the organizations had to navigate the challenges that they were facing during the pandemic. But you know what I would say is I think the waiver is an issue we have to, in Maryland, recognize is part of our go forward. It's not a reason that stops us from addressing anything that you heard us talk about today so far. And I think making sure we have alignment with our regulators and the feds as to how we think about workforce development, workforce wellness, et cetera, is part of the story we tell as we go forward with the next phase of the waiver.
So as you think about the academic side of the house and the practice side of the house, what thoughts do you have about how the nursing leadership, both from the practice and the education side, can work collaboratively to meet these challenges? There's a historical document that's now probably close to 20 years old, in which they asked the nursing deans, how well do you think you prepare your graduates? And 90% said, oh, they're just exceptional. And they asked the chief nurses that same question, and 10% said they were exceptional. So what do you say to us today in terms of the leaders of the two sides coming together and the work that they need to do?
So this is an area I'll jump in where my friend, colleague, mentor, life coach, Dr. Lisa Rowan, and you, Dean Kirschling, I think have demonstrated what the art of the possible is when health system leaders and nursing school leaders get together and think progressively about the evolution and alignment of both education and healthcare delivery. And so the Academy of Clinical Essentials, which is a program that was started between the medical system and the University of Maryland School of Nursing, I think represents exactly the type of collaboration that you're asking about in this question, which is how do we as the health system actually create resources and support for our nursing team members, leaders, who actually take on roles as nurse educators that then allow you in the School of Nursing to scale size of classes to address disproportionately, again, or differently, the ability to educate and bring more nurses into the pipeline. As you, I know, Dean Kirschling, this is a program that started with the School of Nursing. It's now been expanded to other schools around the state. And in fact, Dr. Rowan has been asked by many organizations around the nation to describe how this program, how it works, and how others can look to scale a similar sort of program. One data point from the program that I think speaks to the strength of this kind of progressive thought process is that when we look at nursing students who came through the Academy of Clinical Essentials and then became employed by the health system, when we look at their retention rate, their 1 year turnover, they perform dramatically in terms of turnover. We have a lot lower turnover rate in those with those nurses who were students within this program. So it creates cultural stickiness when we can connect their education experience to their clinical training. And so that's a great example, at least in our minds, of how this collaboration can work.
Dean
So-
Kirschling, I would go also in a different direction. I agree with Mohan's comments, but I would say we have to have a discussion if it's relations to nursing and the development of nursing as to what types of school are going to produce what types of nurses. So for instance, when I look at Hopkins School of Nursing, there, and I have to talk to our board about this all the time, is there are schools of nursing that are designed to develop nursing leaders. And that's both clinical leaders and nursing administrative leaders. And so when I look at that and the practice of advanced practice nursing and needing DNPs and needing CRNAs, nurse practitioners, there are schools designed to do that. We also need schools designed to deliver to the health system bedside nurses. And those nurses are just as important as the other schools of nursing. So my bigger question is, how do we get nursing together and understand how we become more synergistic between the schools and how we're going to deliver what the health systems need in terms of being, cumulative and additive to the care models of the future, as we think about the differences in how nurses go through the different schools and what on the back end they're actually providing in a health system. And I think that's, for me right now, in coming together with the leadership of a health system, that's the critical component, is understanding that.
I would agree with the comments from both Kevin and Mohan. I would just add that I think greater collaboration between the faculty of nursing schools, and particularly as it relates to bedside nursing, which Kevin raised, I think greater collaboration between the faculty of those schools of nursing and the educational infrastructure that all of us have in our systems that is there to support our nurses as they come into the clinical environment. I think looking for ways of collaboration there so that we can actually expand the ability to educate additional nurses is an opportunity that maybe hasn't been fully articulated or fully implemented, because all of us in all three of these systems have significant professional development resources, and being able to connect them in the best way to collaborate with nursing school faculties, I think is really important as we think about how we can increase the pipeline going forward. And that some of that ability to increase the pipeline will require us to think differently about education and what do those nurses require.
Thank you for that. As you think about the pandemic, and I want to make sure that we save about 10 minutes at the end to see if there are questions or comments from the audience. But as you think about the pandemic, what's the one takeaway that you think is going to shape healthcare in Maryland going forward that we've learned from the pandemic? Dr. Drass, would you like to go first?
Sure. So, as I think about the pandemic, I really believe that, and I'm going to take the high level here. I really believe that it validated my thoughts around successful leadership. So I believe that really successful leaders they're agile, they can take risk, they can make decisions without perfect information. They are good communicators, because communication builds transparency, and transparency is the trust of leadership. And as I think about what happened during the pandemic, I see those sort of coalescing in some of the pieces that we implemented. So daily phone calls with our clinicians so that we could communicate with them any changes that were coming forward. And as all of us remember, the beginning of the pandemic, there was something almost every day that was changing in terms of what we knew about COVID. So making sure that everybody had that information. We also, during the surges, really had to quickly become adept at expanding our capacity in order to take patients. And one of the things that we did at Medstar was to develop sprint teams. These were small appointed groups with a single objective that would help us to enhance our operational delivery so that we could continue to take care of additional patients. And two examples of that is how quickly we stood up telehealth, how quickly we stood up patient remote monitoring. I think being agile and learning that those lessons will be very important as we look at the disruptions that are going to come out of the pandemic.
I would say, in addition to what Dr. Drass said, I would say that it wasn't a lesson learned, but it was something that was reinforced, and that's number one, people matter. And why I say that is when I look at what our people did to care for the citizens of this state, it was heroic, and it really made a difference in how we were able to care and respond to the pandemic. Number two, I would say partnerships matter. I look at my dear colleague, Mohan Suntha, and Mohan and I partnered very closely in the state and really did a lot of good things between University of Maryland and Hopkins. And we're stronger together than trying to work apart. And that's an important lesson that I think we need to carry forward. I really appreciate the partnership that Mohan provided during that critical time in our city and in our state, because we were able to make a bigger impact through that. The last thing I would say, and it's not a lesson learned, but I think it's something important when the geopolitical environment became what it did during that, is science matters. And the reason I say that is fact-based leadership, and fact-based leadership backed by science is critically important when there's chaos and when there's differences of opinions. And I would say that for me, that was reinforced of the importance of science when you're, in unknown territory, like we were at the beginning of the pandemic. And so those are some lessons I learned.
Yeah, and for us, I would say, and certainly support everything that my colleagues have said. For us, I would say the pandemic reminded us of the nobility of the mission of healthcare. We say that often, but we have now for our society the tangible evidence of that statement. And the way I think healthcare addressed needs far beyond the acute healthcare needs of people at time of crisis, I think reminded us of our mission, but it also reminded us of the responsibilities that come with being anchor institutions in our communities. A point that Kevin made about the importance of science, and I think being trusted voices in our communities and demonstrating through action why that trust should be placed within healthcare organizations, I think is critically important as we go forward and we, with purpose, take on the issues of healthcare disparities. We talk a lot about health equity today. And in order to talk health equity, you have to call out healthcare disparities, and then you have to decide that you're going to put differential resources to address disparities. And this is the work that we have going forward. But I think the pandemic laid bare some of those realities for all of us, to the point where, again, I think we have that responsibility going forward.
Thank you for that. If folks in the audience have questions, if you could put them in the Q&A, that would be it would be helpful to hear from you. And so one of the ones that has come in, it's the notion of, in essence, you presented an image of better together than better separate. And when you think about better together from a health system standpoint, how do you think about public health and its infrastructure?
I'll start. If you look back at the pandemic, one of the lessons I think we all learned was the importance of, and I know Mohan and I did, is partnering with public health. When we developed a private-public partnership, we really reached out and partnered with Dr. Drass, because Dr. Drass, incredible leader, thoughtful leader, but did not have the resources to respond from a public health perspective. So we supplied resources. And so I think it's going to continue to require that partnership, especially as you think about population health. So in the city of Baltimore, having done a recent study looking at the population, there's a population of 600,000 people, but 33,000 people drive 1.2 billion of the $2.2 billion spend that takes place in the city of Baltimore. So, and if you look at their utilization patterns of how they interact with our health systems, it's not just one health system that they interact with. They interact with those 33,000 people interact with multiple health systems. So to try to do it on our own is not going to be helpful. It's going to take a coalition for us to come together in the city of Baltimore to really deal with the health inequity issues and the public health issues in the zip codes where we know we need to target to improve health outcomes. And so I truly believe that's a lesson that we can take from the pandemic and apply as we think about how we approach that in the city of Baltimore.
Dean, I would just add, and it really is connecting to the comments that Mohan made about trust. I would take us up a level just to say that I think that we are not in as good a place as we would like to be with our communities right now as it relates to trust coming out of the pandemic. I think we went through a phase of healthcare heroes, and it was great, and our people were supported. I think to the comment that Kevin made earlier, our people were supported. They were recognized for the incredible dedication and commitment during the pandemic. But I think more recently, because of the tension in our country, the bond of trust between our communities and our healthcare institutions and public health, for that matter, are stretched. And so I think it is about all of the partnership pieces that Kevin just talked about. But I also think there's work for all of us to do as it relates to reestablishing that relationship with our communities, as it relates to the trust around health matters, and that and I guess going back all the way to the comments about leadership and science mattering and data mattering, I think we really need to work on the issue of reestablishing with our communities through our public health efforts the trust between communities and us.
So there's a question in the box about the notion of advocacy within the legislative arena. And do you have any advice, with nursing being a fairly significant part of the healthcare delivery system, what would you say to us about how we should be working with our elected officials around policy changes that would help us to better address some of the issues that healthcare is facing, whether it be the harm reduction policies or about going after looking at the healthcare policy for marginalized groups? Do you have any advice?
So I would say the work starts now. As session goes, ends in April, what I would say is now is the time where we spend a lot of effort educating our legislators on various issues to bring them to a point of, by the time session is active, that's not the time to try and educate them, right? It is actually, it's the work right now to think about what is the legislation that can move an issue forward, understanding how much alignment there is within the industry, broadly defined, and where are there points of contention. I think any good external affairs leader will understand the points of disagreement well before they go into a conversation with an elected official to start the education process. So I'd say, you know, getting engaged now is important, and then understanding the alignment within an industry and or points of difference as you start to formulate an industry's perspective on whatever the topic is always a reasonable approach.
You know, Dean Kirschling, I would say that having a hospital in Florida, having hospitals in Maryland, and then having hospitals in DC, I at the state level, I'm a bit perplexed as to how to make the most meaningful impact, because the geopolitical environment right now is such that there's such a great divide. To find consensus on some of these issues is not easy in some states at the state level. So I'll start there. At the federal level, getting ready for an election year, as our federal folks will tell us, not much is probably going to happen in DC, except they're going to deal with the debt ceiling and the debt crisis that we're faced with. Because folks are more focused on the election year and focused on the divisive nature of what's going on between the parties right now. And so I would say for me, it's easier to make an impact in Maryland than it is in Florida, than it is in DC, when I think about the federal differences. And you do have to, as a leader, continue to try to influence that. But I do want to recognize the differences when you start talking about how do you impact that at the state level, but also what's going on at the time at the federal level. Those become important key milestones as you think about how to make an impact.
So Kevin, I'm going to quote you on the debt ceiling that you've guaranteed us that it'll be resolved. So thank you for that.
I hope so, because I'm going to come to Mohan for a loan.
Who may go to Dr. Drass for a loan, who may come to Hopkins for a loan.
Right.
Get that collaboration really flying. Well, to each of you, thank you so much for being with us this morning. It means a great deal to us to be able to spend some time with you. We also want to thank you for your exceptional leadership during these unbelievably challenging years, and just wish you all the best. But thank you so much sincerely for your time.
Thank
And
you.
Thank you for having us.
Thank
We're
you.
going to take a 10-minute stretch, and the MDAC will resume at 10:20. So everyone take a stretch, get a cup of coffee or some juice, and thank you so much.